Good evening, everyone, and welcome to AOTA's latest practice chat titled Occupational Therapy and OASIS, Demonstrating OT's Importance Through Proper Data Collection, which is sponsored by AOTA's Home and Community Health Special Interest section. For those of you who are new to AOTA's practice chat series, welcome. For those of you who have participated in previous practice chats, welcome back. On behalf of AOTA's Home and Community Health Special Interest section, my name is Michael Lopez, and thank you for joining us. We have a great session planned for you this evening, and I'm very excited to hear from our guest, Sierra Whitmore. Her presentation will focus on the essential role of occupational therapy practitioners in the OASIS Start of Care process within home health settings. And as a participant this evening, you will gain a comprehensive understanding of the OASIS framework, including its structure, purpose, and how it impacts care planning and reimbursement. Sierra's practice chat will also emphasize effective documentation, with particular attention to how to complete the OASIS Start of Care in a client-centered manner that accurately reflects functional status and specific needs for those receiving OT services. Before we dive into tonight's topic, I would like to review some housekeeping items in order to ensure our call runs as smoothly as possible. If you are on your phone and you haven't done so already, please press mute. If you are on your computer, please mute your microphone. Only the person currently speaking should have their device unmuted at this time. Now, it is my pleasure and honor to introduce our guest. Sierra Whitmore has been an occupational therapist at Stillwater Medical Center Home Health since graduating with her master's in occupational therapy from the University of Oklahoma Health Sciences Center in 2014. In addition to working as a field clinician, she is also a member of her agency's quality assurance and performance improvement team and has been the team lead on multiple performance improvement plans. Her focus on improving quality through care plan creation, interdisciplinary coordination, appropriate use of therapy, and team education has since evolved on a larger scale after connecting with the American Occupational Therapy Association. This has allowed for further advocacy at a national scale across disciplines, including speaking at the National Association of Home Care and Hospice on the role of OT to improve quality and reimbursement, publishing an article in the American Physical Therapy Association Home Health Quarterly Journal on the role of OT in home health, and advocating for the role of OT in home health alongside AOTA staff and members of the Centers for Medicare Advocacy. Welcome, Sierra. Thank you so much for joining us. The floor is yours.
Thank you. Well, thank you everyone for joining us today. So hope you're ready to not be completely bored by OASIS, because sometimes that can be eyes glazing as I talk about this, especially when it's a lot of my coworkers. But again, a lot of the objectives, knowledgeable about the history and advocacy through the years to get to this point. I really, as I started with my initial certification as a OASIS clinician, I did take the COSC exam. I really found it beneficial for me as an occupational therapist, see how we got here and how that stuff that happened 10 years ago is what's now impacting us here. And then able to apply knowledge of what OASIS items impact quality ratings and reimbursement. And well, I can't go through every single OASIS item. I will go over a few of them, especially the ones that impact the most with reimbursement, and where we can definitely show our role as occupational therapy to improve those scores, and to advocate for occupational therapy even within our companies, as this is why we need occupational therapy. And it does help to bring in more money, and it helps our patients be more satisfied, and all the different things that come in with that. Michael already did a great introduction, so I won't go. I do have 2 little boys. I've got a husband. We're in Oklahoma. I've worked in home health for 11 years, and I've got my contact information on the slide as well. So if there's any questions that don't get answered tonight, feel free to email me and I will get back to you as soon as I can. So I like to start off with a little bit of how we got here, why we're not a qualified service, why PDG and why home health value-based purchasing, all this sort of stuff that is currently big words that we hear all the time within our agencies. And with that, we get to see a little bit what the main objective is from Medicare's point, and that way we can better talk to our employers on our use. So 1965, CMS was formed by Congress. Home health really wasn't, in the current sense, wasn't really a thing until CMS was formed. We did have then the 1997 Balanced Budget Act. So I know I'll have my therapists that have, and even some of my nursing friends that have been working that long, and we'll talk about before this, everybody had multiple visits, didn't matter, as many visits as possible. Basically, home health was growing to a significant point where Congress started to pay attention that they were throwing a lot of money at home health, and quickly created the PPS model, which was basically in effect until we had PDGM go into effect in 2020. We did then also have the 2014 Impact Act, and this was to align data collection across post-acute care settings. So that is SNF, home health, post-acute care, and inpatient rehab. This is where we get a lot of our GG codes. That's across the board. And that's what Medicare is technically looking at to see. At a future point, it would require further legislation, but whether there's a way to tell which post-acute care is better for certain diagnoses to encourage people to go that direction. It also led into a lot of value-based purchasing. So how do we get the best value for our money? One thing that's happened as of 2024 was the discharge function score was implemented. This was something that took it's now the Alliance for Home Care and Hospice, but was the National Association of Home Care and Hospice, and then AOTA were sort of taken surprised by the discharge function score, which is now part of the home health value-based purchasing, as it really went beyond the Impact Act, but has now been in effect for a year. And so we're going to talk a little bit about what that is and how that's impacting maybe some of the reimbursement that could be impacting how your agencies are dealing with the amount of visits patients are having. So the first bit is improving Medicare post-acute care transformation act. So that was the Impact Act of 2014. So this, you can see where each of the specific items had to go into effect at certain times, and it varied across. So if you've been in home health for any amount of times, you remember when we first got a GG and complained because they felt like it was the same information as what we got on M scores. We did not always get information on pressure ulcers. Medication reconciliation and follow-up with the doctor was added. And then just recently in 2024, we did have the transfer of health information, where we talk about if you do any OASIS answering at discharge, where you've sent like the discharge medications to. Really, at this point, we've done everything through the Impact Act. And so we weren't really expecting any further changes to the home health value-based purchasing or anything. But Medicare did go ahead and go with the discharge function score. And so that leaves us wondering what else they're going to try and change to better, where they feel like they're going to get the most appropriate data collection for who improves their patients better based off of certain diagnoses. We do also have the OASIS goes into our star ratings. So if there's Medicare Care Compare, this is often included in how you score your OASIS scores from start of care to the end of the quality episode. So either to transfer or from resumption, start of care to discharge, start of care to transfer, and then post-hospital admission to discharge would each be a quality episode. So this is how you improve. So I've got several home healths that vary. It also has the patient survey. So that would be the survey questionnaire that goes out to your patients. But you'll notice that a lot of the items that they're asked about that do impact occupational therapy is that improvement in ambulation, bed transferring, improvement in bathing, improvement in shortness of breath, and improvement in medication, management of oral medications. And then, of course, we had PDGM that went into effect. So instead of being paid per services, having a little bit extra money if you went over a certain number of therapy visits, we're just given a whole big chunk of money. And so the companies have decided a lot of times how we're best going to try and manage those visits, with some of them doing it in different ways. For the most part, the way Medicare says that they figured it out, it should be that what you get now should be the same, similar to what you would have gotten for a similar diagnosis before. Whether that actually is there, probably not. But I know that Medicare has also come back saying that they feel like they've paid more under PDGM than they would have if they had stayed with PPS. And that has resulted in them wanting to do several cuts over the past 3 years. So far with AOTA and other national organizations, most of those cuts have been negated or at least minimized. But that's still something that I know I've heard of a lot of occupational therapists that have had issues with their companies wanting them to do different things. We then also had home health value-based purchasing. So this is where Medicare is looking at specific OASIS items and expecting improvement, and you're basically competing with our home health agencies. And depending on whether you're above the midline out of all the home health agencies in the US or below, may mean that you either get a bump in payment in 2 years or you get a cut in payment in 2 years. And again, a lot of these items are very functional based that we can impact. So this is how the value-based purchasing is determined. So again, you've got your claims base. I'm not really going to go into that. Same with the survey-based ones, but you do have the improvement with dyspnea, improvement with management of oral medications. And then starting in 2024, they started with the discharge function score. The discharge function score transitioned initially. The home health value-based purchasing was based off of functional scores, but now the function score looks at GG. This is the first time that GG scores have actually become important to reimbursement. Up from 2019 till 2024, GG wasn't linked to any form of reimbursement. With the function score, if there is a not attempted code applied at start of care or post-hospital, CMS will use a statistical equation based off of other patient factors from OASIS and GG scores to code it. So we really want to limit not attempted scores because we don't want CMS to determine what the patient's actually doing. And then risk adjustment items are important as well. So even if, as we look at just what it's taking, the main scores for the discharge function score, there's a lot of other risk adjustment items that are also impacting how they score all of this. So for the discharge function score, these are the items that are included. So you can see eating, oral hygiene, toilet hygiene, and then rolling, bed mobility, sit to stand transfers, toilet transfers, and then walking or wheeling for a wheelchair bound. Risk adjustment, and so these are things that are specific on there, but how you score on these items does impact that discharge function score. So if you say my patient's a 3 on toileting, or let's say 1 on toileting, toilet transfers, but then you mark it as a lot of these are having issues, then that's going to actually show them as a little bit worse off to start off with. And so that's going to impact what they're going to determine as that discharge function score. What it also does is that it does a prediction of this is how sick your patient was to start off with. We expect that discharge OASIS score to be this by the time you discharge. And with that home health value-based purchasing, eventually, if you're not meeting what that statistical formula is saying you should meet by the discharge, then that's what's going to deem your reimbursement further. So this is where proper data collection and coordinating with your clinicians and stuff on, because it can be from multiple disciplines on coming together to determine the appropriate OASIS scores can help to make sure you're appropriately capturing your patient's deficits. I have found a lot of this sort of stuff, especially with the confusion, cognitive stuff, but even with safety and sometimes even with management of oral medications, that the nursing just comes in and isn't looking at it from a full perspective. And I have sat in with several nurses on their start cares with my COSC and with the quality and performance improvement. I've said, do you remember how you had to like remind him to come sit down several times? And he got confused when we were trying to go and find his medications and all this sort of stuff. And they had scored him as, oh no, he's cognitively fine. No, he, yes, could have a conversation, but you have to look at all of these things that occurred within it. And we'll go more into depth in some of these specific ones. Like I said, I can't go into everything within the time frame, but we'll go into some. And I bring this all up because I feel like at this point, it's more important than ever that we advocate not just for our patients, but for our profession within home health. So if anybody's in academia, don't shoot me, but I'm not. And so my best form to get any information was a Facebook home health group. And so I put out a poll, and this was back in summer of 2024, and asked, because I'd been seeing tons of posts about people saying, what am I supposed to do? 39 respondents said that they were being told to limit visits by discipline. So this Medicare patient gets 7 OT, 7 PT, 7 nursing, doesn't matter. Limit visits by patient was 46, where the administration was saying, you guys have 12 visits, you guys figure out how to split it up. There was a lot of OT deferred, so until PT frequency completed to extend, they were hoping to extend their home health episode. And then some have canceled OT orders based off of another discipline assessment. I am in a rural county, but there are still 30 home health agencies within this county. And my agency is the only agency that even has occupational therapy. And that's where we're at in our county. I had a conversation with somebody who had a private paid caregiver agency about a month ago, and she told me, I find it very interesting how PT can practice OT, but OT can't practice PT. And we had a very kind conversation on how that was not, but that is where this perception continues to go. And we need to show that OT is very beneficial within the home health. And sometimes that comes into showing them how we improve the patients based off these CMS scores and by reimbursement. So what is OASIS? So this is where I'm going to get into a little bit of how to actually score some of the OASIS items that I've noticed through a lot of my quality improvement and chart reviews with clinicians within my own practice have more difficulty with. So the one thing that we do want to everyone to remember is that you can collaborate. Only one clinician can change any of the scores, but they can collaborate and are encouraged to collaborate by CMS with all other disciplines. Now, for the data they gather, does have to be within a set period. So at start of care, the day of start of care is day 0. Clinicians that see the patient within the 5 days following start of care are allowed to provide feedback on scores and see how the patient is. That can capture whether the patient, sometimes the patient does really good on the start of care because they've actually been taking their medications while in the hospital. And by the time I see them on day 4 and they haven't taken their Lasix in 4 days, they might be a different person. And so we can capture that and better show Medicare like, yeah, they really weren't that good because we need to work a lot on medication adherence and management. So that way we can capture a lot of that. There are, for discharge, you can capture any clinicians from the 5 days prior to discharge, after a, or 5 days prior to a research visit. And then if they come back out in the post-hospital, that's day 0, 2 days after that, any visits can collaborate for that one. As I initially I heard AOT had passed, OTs could perform start of care and rehab cases. And I was like, this is horrible. I don't want to do extra work. It is what led me to do some more research on OASIS and become certified. And I really started looking at the OASIS and was like, this is my OT eval. So I really feel that this is an easy way for us to really show our value within the home health setting. So we'll start in with several. So this is patient living situation. So this one goes into a lot of our risk adjustment items that seems like it's not directly related to any billing, but it does come in through that risk adjustment. So this is all going to be scored based off the living arrangement where the patient was living before the most recent illness. So that's what sometimes gets people, because they might have been living alone, but right now for the next 2 weeks, they've got their daughter living with them. Or maybe they normally live alone, but right now they're staying with their daughter for a month or so before they get better. So so that's where living arrangements, you do have availability of assistance. The availability of assistance is based off of what they have at the time of start of care. And you only count if the caregiver is able and willing to perform assistance. So with this one, a lot of times, so like the patient that lives alone but has a daughter staying with them, or for the patient that's currently living with their daughter but plans to go back home. And if the daughter's there 24/7 with maybe just quickly leaving for a quick, I just need to grab a few things from the grocery store, I just need to pick up my kids, that's going to be patient lives alone with around the clock care. Now, if the patient, this is where it gets really confusing, if the patient's move is going to be permanent, then you would say that the patient lives with other persons. And that's where it gets really confusing. There's a lot of so with any of this information, you can find the OASIS guidance manual, and this is where a lot of this information comes from. There's also a lot of Q&As and quarterly Q&As from CMS that have addressed a lot of this. Patient lives with other persons could be the person that lives with a spouse or lives with family, significant other, whichever. Patient that lives in a congregate, that's going to be mostly our assisted living, senior complex patients, and give them there. Now, if they live in, sorry, I have to remember all my stuff because this one is very complex. So where we also have had issues is a patient that lives alone, but maybe their family lives right across the street and is available by phone all the time, is considered to lives alone, and their availability of assistance is just occasional short term. However, if you have a patient that's in an assisted living, as long as they have a call button or bell system, you would say that patient lives in a congregate situation, but they would have around the clock care. So those were two different scenarios that I know when I did this presentation, part of this presentation to my coworkers, they're like, well, sometimes the family can get there quicker than the ALF. It's just how Medicare has told us to interpret this question. And then, okay, sorry, so patient is still considered living alone, even if they, the other patient is still considered living alone, even if they have 24/7 paid caregivers. So it would only be if a family member lives with them that they would put lives with others. I went over the second one, that even if families staying with them, if the patient lives with others and is occasionally alone for several days, when caregivers traveled, is still considered to be living with others. So that's, I've had several patients, it's like they just is financially more feasible to live together and they have their own life. And then again, if the move to like assisted living is going to be permanent, then you will choose the appropriate, that they're in a congregant or that they've moved in with family so they live with others. Availability of assistance, so the definitions of that: around the clock, 24/7. Regular daytime, someone's there pretty much anytime they're awake, morning, night. So daytime is still like 8 a.m. to 8 p.m. There's not a necessarily exact time. It's more up to there, with infrequent exceptions. Again, they went to go pick up their kids, had a quick errand or something. Regular nighttime, same thing. Occasional short term is someone is in the home to provide assistance only for a few hours a day, or on a regular basis, or only occasionally. So you would choose this if they've got a private paid caregiver that comes for 3 hours, 3 times a week, or if it's just church members that stop by twice a day or twice a week just to drop off food, would still be occasional short-term assistance, even though that's a big variance of the amount of assistance available. And then no assistance would be if there's none. And so if you've got like a patient, their husband has dementia and they're not able to assist the patient, you would say they live with others, but there's no assistance available unless there's someone else involved in the picture that can provide that assistance. Cognitive functioning. So this is another one that I see a lot of my clinicians have difficulty with. Reminder for this one is that this is the patient's function at the time of assessment. So that is considered the start of care and 24 hours prior. And when determining best score for patient, the best approach for this is a bottom up, because we tend to sort of read each one and then be like, oh yeah, that sounds right. And we'll circle it, and we might not have captured just how low they are. And I will say, reading this, there are days that I'm probably a 3 or 4 by the end of it. But for totally dependent due to disturbances such as constant disorientation, coma. So this is our very demented patient, someone with maybe that's had a TBI in the past or something that really isn't very functional at this point. Probably don't have too many of those, depending on some. I don't see too many 4s. 3 requires considerable assistance in routine situations, is not alert and oriented, is unable to shift. So this is, again, where I see a lot of my dementia, especially those that have gotten to where they need a lot more help with bathing, where it's constantly like the hand under hand, lower stimulation environments, really helping them through just daily tasks. 2 requires assistance in some direction, specific situations, are constantly required. So this is my person who they can do their ADLs and stuff, but their medications on a daily basis need constant reminders. Maybe they just have a daughter that needs to call them twice a day. Hey, did you take your medications? So there's some direction specific situations such as medications that requires that. One requires prompting, and this is only under stressful or unfamiliar conditions. I would say that almost every patient is probably a 1. If they're not, then why do you need more than 1 or 2 visits with this patient? Because home health and you being there as an OT is a stressful and unfamiliar condition. So unless you feel like you've educated them and they're good, they're sharp as a tack, you don't need to discuss any of that again, they're probably at least a 1, because you need to make sure that they've understood that information that you've told them that day and that they're actually following through with it. 0 with, again, if you have that one patient, which I have had several where I just tell them that and they're like, oh yeah, and they're giving me a million examples of how to apply it. I'm like, yep, you're good. Probably not seeing you again. So the next one that comes with that is when confused. Now, the last one for cognitive function was the day of start of care in 24 hours. You do need to pay attention to the time frame. So when confused is reported or observed within the last 14 days. So this is if you're doing the start of care, post-hospital, especially, you're wanting to look at some of that documentation. Were they under anesthesia at any time? Did they have pain medication? Did they have some issues with following directions or being confused? So you're going to answer as best as you can based off of that information. Now, if their knee surgery was 2 weeks ago and they're 64, or 66, they're doing good. At the time of start of care, they're probably not confused at all, but you could say, okay, they are confused. And based off, I tend to base it some off of the documentation. If they had a really hard time coming out of the anesthesia, I might say during the day and evening, but not consistently for that patient. If they just had a little bit of confusion that day post-surgery, I might just put in new and complex situations because anesthesia was still in their system. That comes into a little bit of your clinician decision-making. Again, when confused, I would say that most patients, again, if there's unless it's somebody that you told them everything and they can repeat it back and follow through, you're at least going to have a one in new and complex situations. They're just overwhelmed with all the people talking, and you're asking about their medications, and then you want them to get up and roll around in bed, and most of the time they're overwhelmed and they're not going to take in everything that you've told them. Cognitive, behavioral, and psychiatric symptoms. So this one does not have a time frame. It's basically in general within the past, I hate to give it a time frame, whatever seems appropriate. So you can check all that apply. And a lot of times I'll do it's hard to determine all of these necessarily except for the day of start of care. Now you could see that, oh, well, in the hospital while they were under anesthesia, there was some physical aggression or verbal disruption. And so I would put that as appropriate, just because if they had some issues with that, if there's something that kind of is still going on, they get a UTI or something, they're still in pain. Are you going to see some of that verbal disruption during your home health episode? And that will impact your plan of care and how you're able to provide your services. So it's just determining if they had verbal disruption, but it was a surgery that was 5 months ago and they just went in for a UTI, had no issues, I probably wouldn't include verbal disruption at that point. Again, memory deficits, impaired decision-making. So in impaired decision-making, it's important. That's also compliance. Are they following through with their HIP precautions? If not, they do have some impaired decision-making. Memory deficits, if you show up and they're like, oh, okay, and then 5 minutes later, the nurse shows up or PT shows up and you're like, okay, you scheduled both of us. That's sort of a good, okay, we need to be marking that. Disruptive, infantile, and socially inappropriate behavior, which does exclude verbal, and then delusional, hallucinatory, and paranoid. I don't see as much of that, again, except for some of our higher level dementia or traumatic brain injury, neurological patients. But important to put that in there just because, again, if you're having to deal with some of that behavior, that's going to impact how you're able to perform occupational therapy and work with them. So. And then this goes with the last one, that's just frequency of disruptive behaviors. Actually, no, sorry, this doesn't. This is right after. This does not include just the behaviors there. It can include all sorts of different behaviors that may be that are injurious to self or others or jeopardize personal safety. So this could be wandering, sundowning. This could be sleeplessness, getting lost in familiar places. Maybe they don't get like verbally or physically, but they get really agitated or combative and they just want to argue with you, sort of thing, where it's like, didn't quite fit that, but it does fit this. You can include it in this question here. Okay. Supervision and safety assist. So at start of care and resumption of care, they do ask for types of source of assistance. At discharge, they ask for assistance for medications and ADLs and management of the home exercise program. At start of care, this is asking for need for assistance specifically due to cognitive impairment. So this is where a lot of my clinicians will forget, and they're just thinking physical assistance. So this would be something that does need to be some sort of, any of those questions we've asked before would have to have something like, yes, they have a memory deficit, or they are confused, or anything like that. Now, we're not diagnosing them. They might not have a dementia diagnosis. It might be due to UTI. We're just telling Medicare what we see. And at the time of start of care, we're seeing that there's some cognitive issues. So again, at that time, if I'm like, cognition's a little bit off, do they need assistance? And then put the appropriate amount. So getting into the ADLs and IADLs, scores are based off what the patient can do greater than 50% of the time. Do not consider the presence or absence of a caregiver when scoring, and do not consider the willingness or compliance of the patient. So it might be that the patient's perfectly fine to get in and out of the shower. They go in and out. There's no fear of falling. Nope. I've just decided I prefer sponge bath. I've had one patient that basically refused to take a shower until she could get into the bathtub. So I could say, no, you could still take a shower. You just choose not to because you're determined not to shower until you get in the bath. So I could still score appropriately for a shower, and not that they can only just do a sponge bath. Base score on performance before any intervention or environmental modifications. And it can be maybe they're limited because of physical impairments, emotional, cognitive. So that would be the fear of falling maybe is keeping them from taking a shower, even though physically they can do it, or cognitive with your dementia patients. Sensory, if they're just, the neuropathy in their feet just really bothers them. And then obviously environmental. So these first bits are the M scores. M scores are still utilized to determine our initial PDGM functional status. So we do still need to score these. Like I said, home health value-based purchasing has turned to GG. We're hoping in the next couple of years, Medicare will get rid of the M and just switch over to GG rather than doing the duplication. And GG is at least more sensitive to changes with patients, as most of these do not capture if a patient goes from max assist to standby assist or anything like that. Medicare has said that they've kept the M scores longer than they've kept the other scores for the other post-acute care because of the high use of non-attempted codes within home health settings. I feel like they don't take into the fact that of all the post-acute care settings, we're the only ones that are in the patient's home and not in a facility. So it can sometimes be a lot harder to determine bed mobility when it's on an air mattress versus a hospital bed. And there's a lot of places that don't have 150 feet to walk and some of that sort of stuff. So that's some of just the background on why we still have M and GG scores going on. But M, you've got grooming, current ability to dress upper body, lower body. And so what you really need to do is take off your OT cap actually with a lot of these. It's really not, it's looking at what's safe and where they were before. So some of this is looking like their ability to dress the upper body safely. If before they would normally wear a button-up shirt and suspenders, and right now they're like, I can't do buttons, so I'm just wearing a pullover shirt. Even though they can do the pullover shirt maybe independently, it's also looking at what they were doing before. If they were not wearing a pullover shirt before, then you'd say for them to wear their clothing that they would have normally worn before, he would need assistance to put it on. And so that's, again, some of that changing. It's not just looking straight at it like you would a FIM score. It's looking at it from this really holistic, really mindset that also gets really, like I said, it's hard to sort of keep track of everything. So bathing, again, you've got all these different make sure that you pay attention to the use of the word or. So if they need help with 2 of those areas in bathing, then you automatically need to go down to a 3. Again, with like my patient that could get in and out of the shower, was perfectly fine. She just didn't like the shower and would prefer a sponge bath over the shower until she could get into the bath. I would still score her as a 3, even though her performance, what she was actually doing was a sponge bath. Toilet transferring, make sure that so here, 1 is when reminded or assisted or supervised by another person able to get to and from the toilet. This includes walking to and from the toilet. This is not just simply sitting and standing from the toilet. So most of my patients will always be a 1, as long as they require assistance with walking, even if they have everything they need and the actual sit to stand from the toilet is no problem. Here you also have, you can't score if they don't have the equipment. So I go in and they're just using their Depends, and I look and I'm like, well, you could use a bedside commode. And they're like, oh yeah, we'll get that. I can't just automatically score them as a 2 because they don't have a bedside commode. I could know that that's the fix, but I can't score that. So I'm automatically going to go to 4 because they're just going in their Depends. They don't have a bedpan, urinal, or any of that. They're going to be dependent, even if they're able to change their soil Depends all by themselves or anything like that. So that's something to look at there. Toilet hygiene does include pulling up pants as well as all the hygiene there. It doesn't include cleaning out the, emptying out the stoma. Sorry, let me double check. Cleaning around the stoma and like emptying the bag, that is included in toilet hygiene there. Same with like emptying the bag for a catheter or anything like that. That is included in this toilet hygiene aspect. Oh. Yes, you cannot score if the equipment's not there. There we go. Transferring, so that's the current ability to move safely from a bed to chair, or ability to turn and position self in bed if patient is bedfast. So this is truly getting from a bed to the nearest chair. So, sorry, and bedfast only if unable to get out of bed and no available equipment. So even if they need a Hoyer lift, they're a 3. They're not considered bedfast, even though they're total assist. Ambulation, pay attention to and/or usage. So for the most part, so number 2 is the big one, requires assistance of a 2-handed device to walk alone on a level surface and/or requires supervision or assistance to negotiate stairs or steps or uneven surfaces. So basically, this is really only if they have to I had to reread that. Sometimes I'll read these and I'm like, wait, what does that mean again? So really 2s, they're able to use their 2-handed walker. They can do everything except for maybe, and they're independent with that part, but they need assistance just with stairs or uneven surfaces. And then 3 is most of our patients at start of care, they need some supervision. Now they might be walking by themselves, but if they're pushing it too far away, if they're wiggling it through the door that to get to the bathroom and they're not very safe and you're having to say, oh, let's move the wheels to the inside, or here, let's teach you sidestepping, or here, I need you to stand up tall, look up, don't look at your feet, then they're needing that supervision still just to make them as safe as possible and decrease their fall risk. And then feeding or eating is their current ability to feed self meals and snacks safely. And this is on the process of eating, chewing, and swallowing, not preparing the food. Medications. So with some of our changes, I can't even remember when this one changed, with the follow-up and drug regimen review. And this tends to be in our agency. For the most part, we will take all the medications and then we give them to an intake nurse that's in the office, and she will do a lot of that, determining if there's further information that's needed. We will still, as therapists, will fax the doctor if we do notice like there's a medication on their discharge paperwork that isn't in the home and there's no orders for it, or if they've now got 3 different blood pressure medications and from 3 different doctors and trying to decide if they really need all of them. We'll do a lot of that, but we will coordinate with nursing even if it's a therapy only patient at that point. With the medication follow-up, it is at start of care. If you see any medication concerns that need to be sent to the doctor, you write that fax up, you send it, and you need to have the physician's response back and implemented it within 24 hours, the next calendar day. So not necessarily 24. If you see the patient at 8 o'clock today, you have pretty much until midnight the night later after, or to midnight tomorrow, to implement everything. This is where it gets difficult. Sometimes it's on the weekend, sometimes it's Friday, the doctor's left, you don't get an answer. So this is just letting Medicare know we tried to send the fax, we never got the information. If the physician's fax comes in with the recommendation at 10 p.m. the night before, but you didn't, the on-call nurse didn't see it till 1 o'clock in the morning or 8 o'clock the next morning, then you'll still answer no because you weren't able to implement what the doctor recommended with those concerns with the drug regimen review. Management of oral medications. This was one that initially, when we started focusing on this within my agency, realized how much the nurses really had trouble with this because they're stuck on teaching the patients when to take it and how to take it and why it's there, and not so much in the fact that this is truly how they're able to take their medications, and that it could easily be that they need maybe a different type of medication planner. Maybe there's some low vision stuff, that there's a lot of different things that go into this besides just educating them on their medications. So this is actually an area that I've made a lot of progress and actually get referrals now from some of my nurses when they've tried all they can and they know of to help the patient take medicines. And so then they'll pull me in. So just something that can help you to justify like, hey, this is something I can help with. And it's important because it's on value-based purchasing. It's on the reimbursement for PDG, or for PDGM, and it's on the star ratings for patient satisfaction. So it's an important area. It does include the physical ability to access medications. And in assisted living, most of them automatically control their medications, but you still would not score them automatically a 3. It might be that the patient was there because her husband needs a lot of help and maybe she likes having help with the bath, but she's cognitively and physically could manage a lot more of her medications. You would score it appropriately based off of your observations of, is she able to tell you like, oh yeah, I take this and this medication at this time, and she would be able to walk and get herself a glass of water. Maybe she would need help with that. Then you can score it accordingly, even though the assisted living is going to continue to help to manage her medications for her. So finally, we get to our GG scores. So this does look at different, so it does ask for prior function of everyday activities. Assistance is all set up, supervision, verbal, physical assistance of another person. If independent with tasks with adaptive equipment. Yes, sorry. So on this one, if they were independent with the task, even if they needed adaptive equipment, a shower chair, you would score them 3. So that one is the prior level of function. Then you've got the actual scores, and I thought I included, okay, here. So all of these are the GG. Right now, the only ones of these that impact reimbursement are the ones that I had in my earlier slide that include the home health value-based purchasing. It's oral hygiene and toilet hygiene, I think, are the two. I can't remember now off the top. And then you had several on the mobility. Again, these are sound enough that they're like, oh yeah, this therapy base, it's almost like the FIM, but it's not quite, because they're really looking at some different things as well. So it's really making sure you've looked through the guidance manual, and it can help you to further. And a lot of the Q&As, especially back in 2019 when this first came out, there are a lot of Q&As on how to best score this. Independent, obviously, setup or cleanup helps to put stuff up. Supervision or touching. I pretty much put this as contact guard assist as patient completes. And it may be that they need contact guard assist just through part of it, maybe just to help with, well, they're holding contact guard assist while they pull their pants up, but everything else, hygiene, they're good. Or they might need contact guard assist because they're off balance even when trying to move on their toilet. It would still be the same. Partial moderate assist, helper does less than half of the effort. Substantial maximal assist, they do more than half. And then dependent, that they do all the effort or require use of 2 helpers. If it's one of those things where they vary, sometimes they might be like a min assist, and then other times they're a max assist, you're just going to base it off of what they are at least 50% of the time. Maybe in the morning when they're awake, they're min assist, but by the time they hit lunchtime, all the way until 8 o'clock in the evening, they're a max assist because they're getting tired. I would go more with the substantial maximal assist. Again, the GG does have the not attempted codes. We do not want to use these because that's when on start of cares, Medicare says, no, they need to have some sort of score, and they'll use their formula. The only time you can have that the patient refuse. So any with the GG, you can base some off of how they do different activities. So even if they refuse to try and do a stair, 1 step or anything, but they are able to do a step over a 7-inch threshold into the shower, and that was maybe with contact guard assist, I would still score that 1 step for the GG code. But you do have not applicable, the patient hasn't done this before, so that'd be the 4 stairs or something like that. They're on a single floor. All their doctor's offices don't have steps. They haven't done steps in 12 years. I'm not going to work on steps. Not attempted due to environmental limitations. I've done this very few times. A lot of times it tends to be more with the mobility because like their steps that they would normally use are broken, and I don't trust them to hold myself, much less my patient. And then you have not attempted due to medical condition. And this would be something that you have like a true physician's order, like they cannot do steps or they cannot do any of this, and you would put that. I'm just looking, I'm getting close. So this is again just going through a little bit of this. Patient refused and you could not get any collaborate. And you can't always ask. So sometimes they might say to me, like, I really can't do this, I'm tired. I'm like, oh, well, PT's coming tomorrow. I'll coordinate with PT, see if they can see it, and then let them give me the score. Assessing clinician, so on the not attempted due to environmental limitations, the assessing clinician can use professional clinical judgment to determine if a card transfer, stair activity, or other mobility activity may be assessed using a similar activity. So it's raining outside, we're not going to check card transfer. Well, let's see, what about if you back up to this and sit and turn? Are you able to do that? Then you might have an idea. If it's a regular height chair and you required men assist with that, but you've got a big old pickup truck that's 4 feet off the ground, you're probably going to need max assist to get up on it. And so you can score it that way as well. Got 6 minutes. I'm just going to go through some of this last stuff real quick. So it's just future of OT and OASIS. So this just goes into a lot. We do have the Medicare Home Health Accessibility Act that has been reintroduced this Congress. It would make OT a qualifying service, would allow us to really, for me, I feel like I get frustrated because I can't market myself as just OT within my home health. I really, whenever I do presentations with our marketer, I'm like, yes, I can do all these things. I need somebody else ordered with me. So that's the big thing. It is bipartisan. We've got really strong champions in the House. We're working on state sponsors. I say we as AOTA and lobbyists. Andy Bopp's been the main one behind this. And it would expand access to OT. The other thing that came out last year on the proposed rule, so this would have been around July 2024 when this first came out, was that CMS had a request for information on making it permanent where anybody on the order for home health could complete the start of care. Well, right now, if nursing's on, nursing has to do the start of care. I haven't heard anything if they've moved on this information that they've collected for this year, but that just tells us where Medicare's looking at maybe making that a little more flexible and allowing any discipline that's on the order for that patient can complete the start of care, even if nursing's involved. And that is it. I do have like the OASIS guidance manual, the Q&As. I've got information on pressure ulcers, how to grade them. And then the home health quality reporting training manual materials has a lot of information as well. And then a lot of other stuff. I think I've got 4 minutes if anyone's got any questions.
I have a question. Thank you for the presentation. Really good. I do home health care in California, and I was surprised that you said there's 30 companies and the one OT. That doesn't make sense to me how that's a reality unless there's literally no OTs or the other 29 companies are choosing not to hire them for cost saving purposes.
In Oklahoma, there is literally no OTs. So if you want to come move to Oklahoma, we will gladly take you.
Oh, okay. Okay, well that's good to know. Yeah, soon they'll have that, that law where you can jump states without having to get licensure in 50 states or something like that. So
yeah, no. I also work for the legislature for our state, and I was actually at the Capitol yesterday. We're going to try and put in legislation next year to join the compact. So
yeah, I think that's going to be a good thing overall. And then in California, at least, where nobody's really hassling me about managing visits or trying to shortchange visits. It's like I do what I need or want to do, and nobody bugs me.
Yeah. And I know I've seen, like, I work for a hospital-based home health. I know some of the nonprofit and hospital-based tend to be a lot more patient-centered. I know for a while, Inhabit was doing some stuff. And like I said, there are other home health companies that have positions for OT that just haven't. There are some home health companies that don't even have positions for OT and just don't care to even fill it. So there's different things going on. And like I said, being rural and not a lot of OTs in the state. So.
Oh, wow. Well, they'll get there. We just have to graduate them faster.
Yes.
Thank you. Thank you.
You're welcome.
Thank you so much, Sierra. We do have one question in the chat. It says, I'm planning to take the COSC exam this fall. Outside of the references provided, do you recommend any other materials to prepare for the exam?
The guidance manual definitely. What's the other form that I had? If you're unsure on some of the, Wound care stuff, I would definitely, oh, the Q&As. So definitely the guidance manual on the Q&As. If you're unsure on some of the pressure ulcer stuff, the wound care guidelines would be beneficial. And you can have those all, the OASIS Answers that has the COC says that has books that you can purchase that includes all of this. I just decided to, my office actually prints off a lot of these to have them available in hard copy. And so I just borrowed my office's copy of all of this and took it with me in 2 binders to the testing center and had all that. I just had to recertify for this past year. And I thought, I was like, I'm good. I don't need the Q&As. And there were like 10 questions that I knew were answered in the Q&As, and I didn't have it and I couldn't remember the answer. But so those are definitely the Q&As in the guidance manual. If you've gone over both those, you should be good. And I think you'll be very good with that. And then I saw there was another one after that, OTs and other therapists perform lung sounds. Do you find that in your area? And if so, what training did you receive to feel competent in assessing some more of the nursing? So my company does not require that we do lung sounds. It is one that even when I've mentioned it some to my boss, she's like, honestly, it's really hard. And she's like, for most of us nurses, it's mostly like typing up, listening on YouTube what the different lung sounds are. I know just because I have an interest, and sometimes patients will ask me like, my lungs just feel weird. Can you listen to my lungs? And so I have done enough with the nurses to be like, oh yeah, I can hear a little bit of a difference. Now I'll always tell people, I'm like, well, I'm not the best. I will listen. If I hear something, I might call and see if the nurse can make a quick PRN visit or something to really assess. I have at least done enough that I know what a normal lung sounds. I just can't necessarily describe when it doesn't sound completely normal. And so I sort of leave that as my clinical judgment of where I'm good and when I need to call for someone else to come in.
Thank you so much. I don't see any questions in the chat box at this time. If you have any questions, please post it. Otherwise, we will begin to wrap up. Sierra, I want to say thank you very much for such a wonderful presentation. I really love when you said to show occupational therapy's value by showing improvement in CMS scores and reimbursement. And you are so right. The OASIS is our OT evaluation. So we have so much to offer in this area. Thank you for empowering me. And on behalf of our audience members and AOTA's Home and Community Health Special Interest section, I sincerely thank you for your leadership and for all of your contributions to our very meaningful and vital profession in home health and beyond. To our audience members, thank you for joining us, and we encourage you to please stay connected with AOTA's Home and Community Health Special Interest section by visiting CommunOT or checking out our brand new microsite featuring exclusive home and community health SIS resources, publications, and upcoming events found at hchsis.aota.org. Hope to see you next time. Thanks again, and have a great evening.